Hi, everyone. I'm Dr. Vaughn Lauer, and you can tell I've been in the business of special education for many, many decades. Um, I just can't let go. Once you're in, you're in. And those of you who know that know it sincerely. Um, a brief background is I've been a teacher of special education and an administrator at the building level, the district office, and the state level. And I've worked for a couple national companies, including Educational Testing Service. I've got a couple of programs on my website. I've got free stuff on my website. I'll give you a link to that later. What's really important today is introducing you to two people I met. I'm going to introduce Lauren Marone first because I don't know how she found me. I don't know how anybody finds anybody anymore. And then Dr. Ray Stout. So, Lauren, if you want to introduce yourself, please do.
Sure. My name is Lauren Maroney. I am a New York resident. I currently work with Dr. Ray. My son is also a patient of Dr. Ray's. That's how we met. My son has many disabilities that Dr. Ray has helped through her program, which we'll get into later. However, I am a big proponent of the treatment and options available for those with auditory processing disorders, which, in my opinion, very, very commonly go missed. And that's it.
There's more. She's just being modest.
Mhm.
Dr. Ray, would you introduce yourself and give us a nice background of who you are?
Hi, my name is Dr. Ray Stout. Ray is short for Rachel, but I've been going by Ray for 25 years now. And I am an audiologist that focuses on the lost children of audiology. I really like working with the kids with auditory processing issues and with auditory sensitivities like hyperacusis and misophonia. I like working with adults too, particularly former children who grew up with these issues but never fully got past the trauma, because we often can see quite a bit of improvement in those groups as well.
Well, and there's far more she could say. And I want to tell folks she has at least one Facebook group, and I will drop in on occasion to see what's going on. And she does there what she did when I first met Lauren and Dr. Ray is explain it so it makes sense. And that just made the connection perfect for me. I love people who can make it make sense. So maybe Dr. Ray will start with you're explaining what an auditory processing disorder is and then go from there.
I do want to start for a second about why it's very important when people communicate in a clinical way to avoid some of the big jargon. And I think that one of the things that I'm very careful about, because I'm autistic and ADD as well, or ADHD, is that I know that for my brain, I do much better kind of in mind maps or certain ways of thinking that may not go the same way as my patients do. So when we talk and have conversations, it's very important that we can kind of match the words we're using so we can make sense of it together as a collaborative partnership. So in terms of what is auditory processing, you're going to find quite a few opinions. It's going to go anywhere from it doesn't exist to it's absolutely everywhere. And I'm going to say I show up probably, my screen's not mirrored, so I'm all confused. I'd say I'd show up probably about 70% towards the it's much more common than we think it is. Because I think that a lot of what we're talking about with auditory processing is the auditory portion of sensory processing disorder. And it is its own entity, but it has so much crossover with the sensory stuff, with the ADHD, with the dyslexia, with autism, even Tourette's and OCD, that not considering some of these crossovers really takes away some of the power of those intersections that they're all causing problems. It isn't just this one area. It's this one area is the upstream problem. And then downstream, you're seeing apraxia, dyslexia, ADHD, autism, et cetera, et cetera, et cetera. These upstream problems are like sensory processing disorder, including auditory processing disorder, visual processing disorder, and so forth. But when you have multiples of those, they really cause problems coming downstream in terms of what they block. So what auditory processing disorder does essentially is it's what the ears send to the brain, but it's what the brain does with what the ears send. So for one person, you can have the ears sending a perfect signal. The brain takes that and gives it a whatever you call it when you're playing tennis and you give the perfect backhand back, the perfect response, and everything goes, swimmingly, and the person understands everything they just heard. Okay? Versus in auditory processing, you could have issues with delays. So certain sounds get delays, or there's gaps between the sounds that get distorted. There can be changes in the voicing where maybe D and T get mixed up, or K and G, or S and SH. And this kid's hearing like the Charlie Brown teacher, and trying to figure out what's going on. There's all sorts of things that can go wrong when you're talking about the brain. But when you add in some of these other upstream issues like the sensory processing or even the downstream and the stress that can come back upstream, the brain doesn't always know what to do with the information. And there's a lot of overwhelm and overstimulation and covering the ears and hiding and falling behind, especially with language. And I apologize that was a very long explanation. But
No,
basically is auditory processing is what the brain does with what the ears hear.
it wasn't long. It was one of those explanations that I've heard before from you, and I still sit here and go, yep, I understand this. So I'm going to say, see, folks, this is why I wanted these ladies here today. So who can determine the existence of an auditory processing disorder?
In the States, so I can't talk for the whole world, okay, but in the States, only a licensed credentialed audiologist in your state is able to determine auditory processing disorder. I will say for myself as a virtual audiologist, I have licensure across all the states. So I could actually do it from here to Texas, from here to Illinois, for example. And that would be totally legal to do, and it would work really well. But typically it needs to be a person in your state who has licensure.
But do you sit in on school IEP meetings?
Sometimes. The real question is, am I the best professional to be in the school IEP meeting? If I haven't seen the child in person, that sometimes brings up the question of, in the school, of how did you do the test? Which we can easily justify and it ends up fine, but it does take a bit of time.
Yeah. And that's something I want to get into a little bit more, how you do this. I appreciate what you just said, and I understand, and having the right person who knows the child is.
But at the same time, there's so few audiologists available in certain areas of the country that, for sure, a good virtual audiologist is going to be a much better choice than a bad local. So in those cases, if I needed to be in an IEP, I would find a way to be in the IEP.
And I just want to add in here too, Vaughn, is that majority of our reports that we've issued do list out recommendations and accommodations that we do suggest. Our reports are used in IEPs often.
Yeah.
Yeah. And as you said at the beginning, that making those big words make sense. I call it write it in crayon. I wish all related service personnel would get past I have to use the vernacular of my cult. That's a bad choice, but get down to explaining. And so when I work with parents, I say, if you're going to get an independent educational evaluation, make sure the person says, this is the problem. This is how it affects learning. This is how it affects your child, and why these recommendations. Because without that, we just get.
Without that, it's useless. The diagnosis is useless.
Yeah, it doesn't serve its purpose.
Yep.
And that's unfortunate. So how does not yourself, because I'm going to get into what you do, but how does an audiologist typically go about determining the existence of an auditory processing disorder?
So the typical audiologist, let's say in a place like a university, okay, would and I'll just go through the typical one that my son went through about 3 years ago at Loyola University with Donna Pitts. So basically, she first put him through the full audiogram. So she did the hearing test, low pitch to high pitch. So how much power does it take to hear this pitch and this pitch and this pitch and this pitch, and figure out if that's within normal or not within normal. So that was within normal. She did a test of pressure of the eardrums to make sure there was no middle ear fluid. And then she went into the auditory processing testing. From what I remember, she specifically went through the typical tests that almost everybody uses as the basis, which is the staggered spontaneic word list, the Jack Katz Buffalo model test, and she did the Scan 3, which is the like the full battery that does everything from gap detection to competing words to directed ear, where you have to hear this one first, then that one second, which is very hard for those of us that are bad at left and right. Competing sentences, where you listen to one ear and you ignore the other ear entirely. And then there was like a rapid speech. I forget what it's called, sped up sentences, something like that. So that's probably, from what I remember, typically what's done. And that's, I know in Canada, for example, that is the standard of care. I know in the US, we don't have a standard of care. So I think we should take a clue, at least from Canada, to have some standard of care. And that's the kind of most basic test they do. When you compare it to, some people will add a few other tests. They'll add things like phonemic synthesis, where they look at how well a child can hear k, a, t, or k, a, t, s, and put together the sounds. And some of them get to like 5 or 6 sounds. So it's a good kind of like a quick screening of, are we going to see some dyslexia? And some people will do what they consider an attention deficit sustained attention test. But personally, I'm not sure that's really the best attention deficit test, because you can hyper focus on that test and pass.
Yeah. Yes. That's why kids do well on a test, but in real life, it's a whole different world.
Then they come home and collapse. So that's the typical stuff people will do during APD testing, is they'll do those kinds of tests. It's a bunch of tests of speech and noise, a bunch of tests maybe of speech in different areas, although that's more in Australia than here. They'll do different speech in each ear and see how they compete, and whether the child or adult is able to like repeat both words or do it in a certain order. They'll do things with gaps in the sound. Do you hear one beep, beep, or do you hear two, beep, beep? Which can help tell if there's going to be a problem with like S versus Z, F versus V, the voicing kind of issues.
Mm-hmm.
Temporal hearing, and it's an okay test. The reality is that none of the tests are anywhere near as good as they should be. And it's pretty well known. There's papers out there right now that say we don't have a good gold standard, because our testing is based off of lesions and brain tumors. It's not based off of kids and adults who are free of these issues, who just have functional problems. They weren't designed for the kids we work with, but it's all we have.
Yeah.
So the real question comes up is, Dr. Ray, are you sure that auditory processing disorder exists? And I'm going to have to say, yes, I'm sure it exists, in the way I'm sure God exists. I'm sure it exists because there's a space in sensory processing disorder that is the size of a galaxy of kids with language issues. And I know it exists because when I treat it, it gets better.
Yes.
So
Exactly.
the test is crap. I mean, and it's not just me who says it. Everybody says the tests are terrible, but you need the test to get the letter to get the IEP or 504 accommodation. So what you want is an audiologist who's open to the fact that the test is crap. Because now I'm going to look at the test and I'm going to say, okay, so I did this test and then I added 5 more tests just to be sure. I don't necessarily believe that any of them are all the answer we need, but they'll give us at least some firepower to say the kid needs help.
Do those tests rule out anything? And are they beneficial? Not even that. Okay.
No, they officially rule stuff out, yes. But what is it based off of? Considering that the standards are totally not right, based on what I've read about it, Dr. Andy Vermiglio wrote a letter to, or did the 20 questions for Audiology Online, talking about why auditory processing disorder doesn't exist. The problem is it does exist. It's just a far bigger pattern than we're willing to admit. It's upstream of a ton of other problems that it causes, and it worsens. But the way that we're testing it just doesn't make sense. It's not based in reality.
So would it be fair, I'll throw it out there, that if we were looking at the brain, wherever those sections are that are disrupted, would there be, do you think there might in the future be a way to, hey, look, this is why?
No, that's the question. And they actually did look at some of these younger adults and so forth who were showing the same symptoms. They looked at brains, they did fMRIs, they did look, and they can't find the same lesions because they're just neurodiverse. There's something else that's flowing differently. When you look at autistic children, and I'll say this as an autistic adult, there are times when I get so overwhelmed by whatever's going on around me, I just start stammering, and then I'll just give up on talking, And when I
Yes.
look at those kids who become nonverbal whenever things get overwhelming, is it really all that different? Versus having a brain tumor, versus getting blasted by a grenade in the battlefield. Those groups of people which is where we started with this entire idea of auditory processing, they're nothing like the developmental auditory processing children. These kids are perfect. These are damaged adults. I'm not saying they're not perfect, but they've been injured. Yeah. There's a big difference between injury, illness, and born as you are.
I'm sorry. It's just, I'm pausing because it's interesting to think about. Before I want to get to what you do, but what clues might a teacher or a parent see that says,
I would say the 2 most common would be like missed clues or late answers or forgotten directions, like they can't follow multi-part directions, some memory issues, or they're taking a really long time to respond to things, like slow processing. And then I would say, and when you miss things in general, absolutely, like misunderstanding, there's too much background noise. And the last one would be fatigue. when they get into the car at home or when it's lunchtime, when there's a natural break, how tired are they compared to everybody else?
And
And then when on top of that, look at the downstream issues. The downstream issues are going to be speech and language. So how is their receptive language? How is their expressive language? Do you notice them? It's not the right word, gerrymandering, trying to take over all conversations so that they're predictable to them. Do they try to like force their way into conversations so that they're not left behind? Or do they go silent? Do they retreat?
And some of that, you mentioned earlier, some of that explains, I see a lot of postings on my Facebook group. There are over 10,000, and I'll often see children with autism, ADHD, and then once in a while somebody will say auditory processing, or they'll have those two plus dyslexia. And,
Well,
and I've, go ahead.
they're saying that, I mean, they're saying adults might have up to 60 to 70% auditory processing issues by age 50. Now, if that's true, how do we get from 2 to 5% in childhood to almost 70% in adulthood? There's got to be more going on in childhood. And I'll tell you where it's happening. Autism and ADHD. Because autism,
I can
they're
tell you,
saying,
Vaughn, just from my own experience, my son was misdiagnosed as ADHD and he had auditory processing. We put him on medication. We tried everything, and nothing was that magic bullet that they said would happen with a Ritalin type medication.
or it could be both. For some of the kids, it
Yeah.
could be a combination of the two overlapping each other. It makes sense that an auditory processing issue would overlap with ADHD when you consider that ADHD is basically high functioning autism, or however you want to call it. It is very similar to autism that has lower needs.
Yeah. So, I mean, Michael, my son, Michael, he was presenting as typical ADHD. However, we did not know about auditory processing disorder because our care providers at the time were not aware or knowledgeable in the field.
Mm-hmm.
So we medicated, and we tried that for about a year and a half and did not see any improvement. We tried many different types of medication because they do say not everyone works for every child. You have to find the right medication. And we just weren't seeing any improvement in the areas that he struggled in. He then eventually tested as dyslexic. And I decided to hire an advocate to come to my IEP meetings with me because I was uninformed and I was not knowledgeable on the processes of an IEP meeting. And the advocate took one look at him and said, he has auditory processing disorder. And I never saw, he would say what if he wasn't looking at your mouth. He was constantly looking at my mouth while I was speaking. As a parent, I said, he has great manners. He's, making eye contact with me, all of these signs. Now I look back and say, wow, how could I have missed that? But there are a lot of overlap with these issues. As Dr. Ray had said, it's usually not just one.
The other one that I think is really important to mention is the overlap with hearing loss. And for example, little kids, 1, 2 years old, who have the fluctuating hearing loss from middle ear infections, and the fluid builds up and it drains back through the eustachian tube and it builds up again. And they could go for 1, 2, 5, 10 a year, months of not hearing well, meanwhile getting auditory deprivation. We should be fitting those kids temporarily so that they never go a day or two without hearing. It would fix so many issues.
Even with the infection, the hearing support would work.
Well, I mean, the infection's behind the eardrum, so as long as you can get the sound loud enough to get past the gunk.
Okay.
Yeah.
Yeah.
So I do think it's important to say that hearing loss and auditory processing disorder are very, very similar. Hearing loss is like a peripheral problem. It's in the ear. It's the ear canal. It could be wax. It could be the eardrum. It could be the middle ear bones. It could be the cochlea, or it might even be the little auditory nerve that goes up into the brain. And that would be considered hearing loss typically. Once you get past the auditory nerve, it's auditory processing land.
But
Yeah.
Dr. Ray, your analogy, and this is Vaughn, an analogy that I love that she uses, is
Oh yeah.
a strand of Christmas lights. And if one bulb is out towards the plug or one bulb is out in the middle, they all turn off. It doesn't matter where the problem lies, in the sense that we need to find a way to help. Does it matter where, this issue is occurring, if it's in the brain or the ear? That's, the same argument with glasses. Does it matter if a glass helps somebody, but it's an ocular nerve issue or a retina problem? The glasses are helping.
Yeah.
Does it matter?
Yeah.
And unfortunately, not that APD has a stigma, but it's not as researched as other ear issues. And that, to me, is a disservice.
Well, and the fact is that hearing aids, and even with these low gain hearing aid options, are still very, very stigmatized because people think it means that you're deaf. I tried it with my son also, who's autistic ADHD, and I think he's planning to use them next year for middle school. But when I first tried it on him, he's like, they all thought I was deaf. But we also are in a school system where about 10% of the kids are deaf. So it's a little different.
Wow. These data are frightening. All right. That was a nice segue to Dr. Ray. How do you make a determination of auditory processing? What are the steps that I know Lauren is a part of this? How do you guys do this and then serve?
Our method's a little different. Ours is a little different. So we are a virtual audiology practice, which means that we often will take testing from other clinics, at least for the hearing test. If it's from a clinic with a calibrated system and it's clearly an audiology practice, we'll accept it as a test. Showing up is totally normal. Until we have more proof, it's probably normal, but we'll be looking. We keep our eye out. So
and the reason I'm asking is schools are going to ask that question.
Oh no, absolutely.
What is the validity? And go ahead.
So what we do next is we take that information, and with the parents, we send them a set of headphones that are calibrated for the auditory processing testing, or we have them order them from Amazon. It doesn't make much difference. They're only about $10. And the people who've been using these same calibrated headphones are Acoustic Pioneer, which is one of the biggest test manufacturers. They believe they are calibrated enough to do testing through virtually.
Good.
Although they do primarily, about half their stuff is through the iPad. The other stuff they do is computer. So what we do at that point is we very often will actually send out an iPad because we want to do this Feather Squadron as a possibility. What's nice about Feather Squadron is it's really inexpensive for us, and it's really inexpensive for the people we do it with. And when I talk about inexpensive, we're talking, about $150 for 2 full reports, one for when they're awake, one from when they're tired. Okay, it's really not bad. And we can take that information, and if it's useful information, we can take that and the cost that they paid and put it towards our regular full battery, which is just under 1,000. And we're able to take that information, and it includes a bunch of things that we wouldn't have had otherwise. It has a pitch measurement, looking at how well the child can hear patterns of pitch. It has some tone comparisons. It has some word memory. It all depends on the age of the child, but it has what I like that it's not a linguistic test. So when we get the kids with autism who are really not speaking much, or when we get the selective mute kids who won't respond verbally, we're able to have them just respond by touching something as opposed to speaking. So
Right.
it's at least something.
Mhm.
So once we're done with that test, we have them take it once when they're more awake, once when they're more tired. Okay? And we compare the two to look for fatigue. This is something nobody else does. Nobody else looks at, does fatigue make a difference? And the reason you can do it with Feather Squadron is because it's not a memorizable test. It's too nonverbal. You can't memorize this test. Therefore, we can make you take it twice in the same day and you still can't remember it. So that's really nice. We take that test and then we'll go back in and we'll do the typical what everybody else does. We'll do the staggered spondaic word list, upstairs, downtown, and the two overlap and you have to hear, up and then stairs and down are actually overlapped with each other. So you have to say upstairs, downtown. We have the scan, which has all of the gaps in the sound, the sped up sounds, the competing words, the competing sentence, you ignore one. We can do phonemic synthesis, which is the measurement that's like, is the person likely to be having dyslexia issues in the early stages? At some point, I'd like to get some more further testing, like some Lindemood Bell, but at that point, I think I'd need to have a speech pathologist help me with the testing. And then it would require a speech pathologist registered in all the states.
Oh, yeah.
That's an issue. So what I need to look at is which tests am I allowed to do as an audiologist so I don't have to get somebody registered in all the states.
Got it.
Or which ones don't require certification other than a degree. In any case, what I do after that point is I test them the SSW, as I said. I'll do the scan, I'll do the phonemic synthesis, and we'll do also the low gain hearing aid trial, typically. So then we'll spend 6 weeks with this person, typically, sometimes 8, particularly if they're very sensory. And we try them with the hearing aids to see, is there a benefit?
Sorry to interrupt, but would you explain what that low grade means?
So low gain programmed hearing aids.
Sorry.
It's an alternate way of programming conventional hearing aids so that it takes a person whose normal hearing is more comfortable and they can hear soft sounds more clearly with loud sounds being less unpleasant. It helps to filter out a lot of the noise in the signal so that their brain doesn't have to get as tired.
Thank you.
So I just want to add that trial is something that we are the only people that do that.
I mean, people do trials where they'll have people pay in full, for example, and they'll say, whatever the cost of the hearing aids is, pay $6,000 or $8,000, and then in 30 days, if you don't like it, we'll give you back your money. We're not doing that. We're basically not charging for the trial other than as a security deposit, and there's no money that we're keeping from the trial. I mean, it's the cost of shipping and the cost of a video otoscope that we send. That's the only cost in the trial that doesn't get returned. So it's really a different, we're doing the trial as a diagnostic trial to really see, is this helping? Is it not? If it isn't, what does that mean? If it does, what does that mean? And, considering that we're seeing between 70 to 80% or so of people with auditory processing issues, whether or not they have multiple issues. I'm assuming auditory processing or auditory processing plus, The misophonia people and the hyperacusis, I'm going to say, are closer to, misophonia is closer to 60, misophonia is closer to 50, hyperacusis is a little closer to 60. They're harder because they don't have because they're not bad enough. They're not hitting the disability critical point where they're having enough trouble hearing. These groups of people, misophonia, are the people who are bothered by people chewing, people slurping, lots of body noises, tapping, even some movements. If they're repetitive, they bother this group of adults and kids, and it's horrible. It makes them just want to choke people or hit people or run away. It's really bad. It's to the point that they'll build separate wings in the house. They'll get their kids another apartment because they can't live in the same space anymore. It's that bad. So anyway, I work with misophonia very often lately because it's interesting. And APD is getting a little easy. Well, so the misophonia, those two, it's not as high of a success rate. But for the ones who do well, they continue to do well. We still haven't seen a return in 5 years.
Wow.
I mean, we see them for sure in the trial. But once they get to the end of the trial and they say, I'm sure this is helping, they don't change their mind.
Yeah, I talk about feedback that's relevant to the analysis. This is it.
Mm-hmm.
And I think it's a nice concept to say that I'm not committing to thousands of dollars before I see if this is really helping my child, given the
Exactly.
fact that there is no gold standard. I think that is a very important piece to mention because
Well, it goes
without a
beyond
gold
that. There's
standard,
no
right.
standard at all when it comes to programming. It's even worse than the standard of testing. The standard of programming goes everywhere from people just making up random stuff like, oh, this person has a 35 decibel hearing loss. I'm just going to say that, and then I'm going to hope that it looks good enough, and I'm going to put it on this child. That is what we are talking
it's
about, the level of
dangerous.
standard
Yeah.
that's going on. And
And I do have to say,
they're not doing any questionnaires afterwards to make sure these kids are doing okay, or sometimes they are. Who knows?
a lot of times Dr. Ray will also, even just this last week, Dr. Ray, she meets with other audiologists that are in other countries and tries to help them to say, okay, this is how I'm doing it, and this is why I'm doing it this way. And the reason she does that is because one of the main reasons why I love working with Dr. Ray is her ultimate goal is to help people. This is not for her quick get rich scheme. She genuinely sees a difference in these children and patients, and she wants to continue that even for areas that she may not have access to.
I mean, the truth is, we can't see every child. We can't. And I believe that a lot of the things that are going on are almost abusive. Like the level of language deprivation that's going on with hard of hearing and deaf kids, I think is absolutely terrible. And if I'm going to have any impact on these kinds of things, I need allies. And honestly, the best way to make allies is to be open about what you're doing so that people can use your resources.
Your sincerity, both of you, comes through, and that's why I wanted to have this interview. I want other people to see, I don't want to say honest, but people who will be listening to this will understand the value both of what you're doing, and no, you're not trying to get rich, because I can see people willing to pay a lot more than what you're charging. Well, what differences, and it's almost an ignorant question because I know part of the answer, but what differences could parents and children with auditory processing disorder experience?
So
You want me to take that first, Dr. Ray, just from my personal experience?
sure.
So I am a parent of a child with auditory processing. I can tell you that Michael, my son, was struggling immensely with self-confidence. It was hard for him to be in a group setting. It was hard for him to be in a classroom setting. They initially fit him with an FM system, which kind of made him feel even more secluded and more in a bubble. It was hard for him to make friends. He was grade levels below his reading, full years. So in 6th grade, he was reading at a 1st grade reading level. He was severely dyslexic. We had gone and gotten testing from a local audiologist who actually is well-versed in APD. And she had told me that Michael was one of the worst patients she has ever seen. He tested probably the lowest that she has seen in years. And we got this diagnosis 3 weeks before COVID shut down everything.
Yeah.
And I knew that the virtual schooling was going to be difficult for Michael. I didn't really anticipate how difficult that was going to be. He started declining even quicker, and I decided I can't wait any longer. The audiologist that we had seen was completely shut down. She wasn't treating any patients. In fact, she went to Florida and just never reopened.
Oh,
And through research, I found Dr. Ray's group. And I was reading testimonial after testimonial of these people seeing this almost unbelievable difference in their children. And I said, how could I not? There's no risk. How could I not get him the trial? So we got the trial. And the first day he had it, we sat down to watch a movie as a family. And I said something to Michael. Now, his typical response would have been to turn to me and say, what? So that he could see my mouth,
Yep.
say it again. And without even moving his head, he answered my question.
all right.
And I said, oh my God, what the hell was I waiting for? We have seen leaps and bounds with him. He's no longer, after 3 years in the trial, he no longer tested dyslexic. He stopped all medication for ADHD. He had caught up to his grade reading level. He is now at an average student, except for math, which I don't know if that's his problem or genetic, but he is at grade level for all of his subjects. And it was such a monumental change for such a little piece of equipment
Yeah.
that I said, there's no way I can't shout this from the rooftops. Like, this is life changing. And the more that I was researching and working with Dr. Ray, the more people I see with the same story. It's the same thing over and over again, where these kids are, it's not just little changes, it is leaps and bounds. And I would be foolish to not get behind a movement like that after it's helped my family so much. But I'd be foolish.
And you were right in the beginning of it too. I mean, when you think about when I first tried this, it was 2013. And then you ran into me in 2017 during COVID summer. And then I kept
20.
Was it 2020? Oh,
Yeah.
okay. I'm doing well. 2020 during COVID summer. And then we kept all of those people afloat through that summer because we were worried about what was going to happen to people financially. I couldn't do it. I had the life straw for the creek, I just could not do anything until September, October the next year. And then, yeah, I'm so glad you're aboard.
Thank you. Me too.
So the kinds of things that we have seen, okay, and I don't have my exact percentage numbers, but these are all in the 60s, all right? We see kids and adults coming back with more energy at the end of the day. That's probably second, okay? The first one is better mood at the end of the day.
Mhm.
Followed by more energy, and then recognition and progress in speech articulation was added by one of the parents. So I suppose it was something about speech artic. So faster response to speech was the next one, which is what I had said. Higher grades because child can understand teacher, fewer and less severe headaches, better or easier sleep at night, decreased anxiety, decreased ear pain, child has better peer-to-peer relationships in academic environment, and reduced ADHD symptoms, including hyperactivity, reduced falling, better balance, improved OT crossing the midline, better visual and spatial skills.
And that's a lot. A lot of those are social behaviors. And
Absolutely. And if you think about it, a lot of them are really spoons. So remember I was saying upstream problem, downstream problem?
Yeah.
So if you take away some of the effort the person is having to do in terms of sifting out speech from noise, How much more will they have for things like executive function? How much more will they have for balance or memory, you know? And if you think about it, a lot of those downstream problems have to do with not having enough resources.
I'm sorry, in terms of,
So, like, if the upstream is sensory, let's say, sensory including auditory, all these things using up huge amounts of cognitive resources.
yes, well said.
Downstream, a lot of these issues, like dyslexia, like ADHD, like the autism that comes from all the sensory stuff, a lot of those things are made a lot worse because of a lack of resources that are getting used up high, upstream.
Oh, okay, I thank you.
So imagine like a tree or a rock knocking out half of a waterfall. How much water is actually going to get to the bottom?
Yeah, I can tell you Michael was exhausted just from listening to his teachers every day in the classroom. And then he
Which
would have
is,
to come home and perform for homework.
And
And
remember it. How do you
he-
remember it after that?
Yeah, he used every ounce of his ability just to be able to try to organize what he was hearing,
But
which he wasn't.
and we hear a lot of times there's a lot of kids that are coming home from middle school and high school now that were falling asleep in the car on the way home, and now they're not, and they're getting home able to do the homework. They're able to do their swim test. They're able to do one more thing without falling apart. We're also seeing really big changes with some PDA kids, where you would think PDA doesn't have anything to do with this. You want to bet? PDA is an issue of missing cognitive resources. They're using them all up with anxiety.
and for those who don't know what PDA is, could you explain that, please?
So pathological demand avoidance is a version of autism or a presentation of autism that has a lot to do with anxiety and the inability to deal with demands from other people or themselves. So you can have a person who has pathological demand avoidance who might not go to the bathroom for the whole day because they're so bothered in some way by the need. Like, how dare my body betray me? I cannot give in to this, no matter what I do. And there's a lot of paralysis and getting stuck in loops of anxiety and thought within this population. What we're seeing with this group of kids very often, and I haven't seen very many adults with PDA, is that as the demand on the hearing decreases, they have more left over to deal with their annoyance at other demands. So you're not seeing as many meltdowns. You're not seeing as angry reactions because they have more space before they hit that barrier that that they're so bothered by, that feeling of control by someone else.
And I know I'm nodding my head. I just caught myself, but I'm nodding because I fully understand it. And I think the audience that will be listening to this will as well.
I think that they should also be aware that we've seen a number of pre-verbal and lower verbal children who've started talking because they could hear themselves better and they weren't as bothered by the noise in the room. We had a pair of 3/4 twins, one of whom we started at 3.5, the other at 5.5. Let me tell you, the 3.5 kid is now basically fully conversational. And the 5.5 kid is echolalic, but is responding and is taking instructions and is really starting to finally communicate, but is more than 2 years behind the 3.5-year-old.
And so folks know, we're not saying this is the cure for everything.
Right.
What we're saying is, and why I wanted these ladies to come talk with me, is here's something that you can look at. And both of you are reasonable people, where you could literally be charging a lot more than you do. But you have the data to support the differences. And the fact that you give a trial, I think is essential. and you make decisions from there. I don't have any other questions, but I would love for either or both things you'd like to add.
Let me add in one last thing, because I didn't get into this, is we take the trial very seriously. If a person shows a very significantly positive response to the trial, and if they need that stamp, to say they have APD, I'm going to find a way to make that happen, because they clearly had a problem. I'll give you an example. We have a patient who works at a plant, like a factory, and he had gone in for an APD test that was totally within normal, but this guy is really struggling. Like, in the plant, it's too loud, he's not picking up people's voices, and it's not safe,
Yeah.
We fit him with some low gain hearing aids, and he's only 3 or 4 weeks into that right now, but he can hear the people at the plant without a microphone, which is a big deal because it wasn't very safe for him. And, it's really, in my opinion, up to the person themselves, or their parents anyway, to determine like the right to control your own body. And this is not a dangerous thing to try. It's about as dangerous as putting on a pair of polarized sunglasses that were just a little more customized to a prescription. And if it makes a big difference, you'll know. And if it doesn't, not a big deal. But I think the main thing is, when you look at it, is if I see a very noticeable change, I'm going to consider that as part of my test.
And Vaughn, I really wanted to add on to your statement just prior of, this is not going to fix everything. No, not the problem, the problem solver for everyone, for every issue. However, I believe, especially in the special education community, it's important to look at all the pieces of the puzzle, okay? And a lot of time with parenting, even non-special education children, it becomes a puzzle. And if this is one piece that makes something a little clearer and makes the picture come a little more into focus, I think that it's important to talk about. And I think that goes across the board for anything that is offered to this community.
And I think we have to really look at, what the potential is beyond the typical population. Like I was talking about misophonia, for example. So I was just working with a girl who is last year of high school with misophonia, totally normal auditory processing, normal. But she's so normal, she could sit in a room and hear somebody chewing 2 doors down outside and be so bothered by it that she'd be having murderous thoughts, So normal or not, that is not normal, and that is not okay to have to deal with and not be able to shut it down, So what we did with her is we said, look, check this out. You can use earplugs on top of the hearing aids. You can just stuff a little piece on top, and then you'll only hear what comes in through the hearing aids themselves. Here, hold on. So if you stuff a little piece like right here so that it blocks off the entrance of the ear, then all the sound comes down the wire. And then if that's not enough, you put headphones on top of it. And if you do that and you use the headphones on top of it, you're thinking, but then you'll never hear anything. But that's not true. This is a Roger microphone. So for this kid with misophonia, this young lady with misophonia, she's able to point this to whomever she wants to in very sharp directionality. So just this person, maybe somebody right next to them, and listen to just the person she wants to listen to, but not have to listen to anything else. Which means the difference between being able to have dinner with your family, which means the difference of being able to live in a household. So I don't think that this is more handicapping than what's going on now, which is exposure therapy. Let's just, force you to listen to things that are painful or uncomfortable, and eventually you'll give in. it doesn't work so well either. So my point is, this is another neat thing that you can do with these.
Yeah, I love that you have options.
Yeah.
You do.
I think it's important to realize that not one size fits all. And even if your group does not wind up going with Dr. Ray, if they do feel they wanted to do this trial or anything, I think it's very important to make sure that you're going to an audiologist that's well versed in auditory processing disorder if you feel that that is a possibility of what may be going on. A lot of audiologists that don't understand it, don't try to understand it, and will dismiss the issues that are happening. And I think it's important to not allow your child or yourself to fall through those cracks.
There's a lot
And
of
we as
people.
educators, I'm sorry, we as educators do that too. If we don't
Yeah.
understand it, we don't try it. And because there's been so much that have come to schools that years later have proven ineffective. And sometimes, I'm sorry, educators go by their gut or a political choice versus research. There's my little venting. Dr. Ray, you were going to say something.
Just there's so many kids that probably have issues in these areas. And I will say, as somebody who grew up where there was like a sign interpreter in every one of my classes, that was really, I mean, it's really something that can help a lot. So when you talk about, for example, kids that have these issues, sometimes they get so bad that they function like they have a hearing loss. And we have a few of them that are actually have sign interpreters. And it's something that they can kind of move towards for college, for if they need it as well.